We now turn to a summary of the findings and contributions. This thesis was primarily motivated by twin phenomena, right? Two things: falling long-term care services use and unrelenting deleterious effects on informal caregiver well-being across urban societies. These phenomena run counter to the needs of aging population that present challenges of chronic illnesses, long-term disabilities, and crowding at acute treatment facilities. The limited effectiveness of simply increasing long-term care supply to meet these challenges has led to transformation of healthcare to influence demand for long-term care use. Using 3 studies, I investigated the extent to which informal caregivers' subjective well-being influences the utilization of public long-term health and social care services. In summary, Study 1 showed that elevated caregiver burden, depression, and poorer health status are non-causally associated with increased utilization of LTCS services. Study 2 showed that increased caregiving burden and increased caregiver depression are prospectively and concurrently predictive of stroke rehab use at 12 months. And Study 3 showed that non-distressed caregivers at 3-month post-stroke and 12-month post-stroke were likely to have cared for stroke rehab users at 12-month post-stroke. There are 4 main contributions to knowledge. The first, caregiver resilience should be studied further. Right? In Study 2, caregiver depression was predictive of stroke rehabilitation use, but in Study 3, non-distressed caregivers were more likely to have cared for rehabilitation users. This disparity across studies may be explained by the possibility of a coexistence of positive and negative caregiving experiences, such as resilience. A depressed caregiver may not experience distress due to effective coping strategies and a sense of self-efficacy. Some caregivers may be able to bounce back from adversity. Others may experience satisfaction and positivity. Therefore, this thesis calls for further research into the possibility and nature of this coexistence between positive and negative experiences in caregiving. Second, educate and intervene on caregivers' subjective well-being early. To my knowledge, studies 2 and 3 were the first to provide quantitative support for the importance of early and sustained psychosocial intervention to informal caregivers of stroke survivors. These results are supported by qualitative research reported earlier that is associated with programs aimed at informal caregivers of stroke survivors. Unfortunately, in the literature, the available psychosocial interventions for caregivers of stroke survivors are few and unstructured and should be enhanced. The third one, long-term care service use explanatory frameworks should include caregiver subjective well-being characteristics separately from patient characteristics. Prior to this thesis research, informal caregiver subjective well-being constructs have been categorized by some researchers as need factors of the prevailing Anderson model. As you could see here, my research provided evidence that caregiver characteristics should be distinguished from patient characteristics in their explanation of long-term care use. Caregivers and patients should operate in different contexts, although some characteristics may be shared. Finally, caregiver-patient diet in integrated care. The evidence presented today add further weight to the presence of joint decision-making between patients and their informal caregivers regarding long-term care use. Informal care appears to be the first choice of care. Patients prefer to age in place rather than to be institutionalized. The consideration of formal long-term care use appears to begin when informal caregiving is no longer able to provide satisfactory quality of life to patients. Therefore, informal caregivers' subjective well-being should be factored into integrated care service design and delivery. Okay, this is my final slide. This thesis was motivated by these 3 rationale: the twin phenomena of low long-term care use and unrelenting deleterious effects on informal caregivers. Right? These gave rise to this main aim to elucidate the contribution of the role of informal caregiver subjective well-being in explaining formal long-term care use. Via 3 studies, I elucidated this role based on a systematic review and meta-analysis, as well as quantitative analysis of primary data collected in Singapore, I found evidence that elevated caregiver burden, depression, and poorer health status are non-causally associated with increased long-term care use. In my view, these findings contributed to 4 areas of research. Thank you.